All right, this is take two of the GIGU liver, biliary tract, pancreatic issues module 17. Medical Surgical Nursing 1, Semester 1, Nursing 162 with Professor Ayman Amin. This is Spencer Tuma. We're going to be going over these topics today. It's going to be a good one. First up, we're going to go over the GI issues, GI tests, diagnostic tests, urinary tests. Then we're going to talk about the liver, uh, mainly the biliary tract and pancreatic issues associated with that. So let's start with the GI issues. First up, we have the diagnostic tests overview. We have a couple different tests that we do. We're going to do occult blood sample. We also have our typical stool sample. Um, that's going to be just submitted to the laboratory in the urine specimen cups, and that uh, is pictured there with the orange top. We also have the occult stool slide right there in the bottom left. That is used. We'll talk about that in a second, actually. The other two things we want to be aware of with the GI system are EGDs and colonoscopies, esophagogastroduodenoscopy and colonoscopy. So when we do a stool sample, just a bit regular one, submitted to the laboratory, this can be used to sample for ova, parasites, and bacteria. We want to fill this up about 1/3 of the specimen cup, label it with the patient's information, double bag it, and put it in the. You actually can send these, they're not glass, so you can send them in the tube system at Cottage Hospital. For this, you don't want to have the patient void in the toilet. You want a clean sample taken from different areas of the stool. So for the occult blood stool sample, we have the slide here. A small bit of stool is applied to the little areas for the stool. The slide is then covered, and liquid is used to interact with any possible blood in the stool to identify trace amounts that you can't see with your eyes. So um, blood can be in your stool for a variety of reasons. Probably some of the more common ones are just GI bleeds, ulcers, peptic ulcer disease, lesions. I've seen a lot of esophageal varices causing GI bleeds due to chronic alcoholism. Um, but there's a variety of issues that can cause blood to enter these stools. You want to be aware that if the blood is bright red and coming out of the patient's rectum, it's going to be a lower GI bleed. This is frank blood that has not been digested in the small intestine or the stomach. Or if it's upper GI, it might have a coffee ground texture to it. And the most unmistakable thing about a GI bleed is the smell. Once you smell a good GI bleed, you'll never forget it. It's disgusting. Um, Sometimes you won't be able to detect any blood in the stool just with your naked eye, so occult blood stools can be a great way to do that. Another common disease you'll see on a lot of our test questions is going to be C. diff causing blood in stool, cancer, polyps, hemorrhoids, lesions of the intestine, certain types of infections, ulcerative colitis, Crohn's disease, and diverticular disease. So before the patient gets the sample done, you want to have them avoid certain fruits and vegetables, broccoli. You really want to have them avoid red meat that can have blood in it and cause a false positive of this test. Vitamin C supplements can cause a false positive, as well as you want to have them stop taking maybe uh, blood thinners that they might be on at home, like aspirin. Um, this can cause bleeding in the gut that is somewhat to be expected, but we want to make sure that all the massive bleeding is taken care of. So the other diagnostic tests that we have for this would be this gastroduodenoscopy. What a name. This is a tube with a camera on it that is inserted down the patient's throat. I've seen it done at bedside. I've seen it done in a specific area of the hospital where they're meant to do this endoscopy. Um, but for the most part, uh, the patient is under light sedation, they're kept in bed, and this is done to diagnose massive bleeding, to remove polyps or clear the clear the pathway of lesions. Sometimes they can ablate areas of the GI tract to stop the bleeding. That would be applying heat. Other times they can remove it with like clippers and then stop the bleeding that way. The EGD is used in the upper GI system. It visualizes the esophagus, the stomach, and the duodenum. Um, but beyond that, like once you get through down into the small intestine, you start having issues viewing anything, and um, this is commonly used to diagnose anything in the upper GI bleed area, gastric lesions, and it can also be used to diagnose celiac disease. I'm not exactly sure what they're looking for with celiac disease, but that's what it's used for. So what you need to be aware of as the nurse, if your patient is getting an EGD, the patient is going to be NPO 6 to 8 hours before the procedure. Sometimes they forgo this, so you want to have suction set up at the bedside, ready to go if they're going to do it bedside, or they will have suction down an endoscopy ready to go. You don't need to do bowel prep for this, but you should be NPO, clear that upper GI system out. They might use moderate sedation, but for the most part, this is done at bedside. The patient's head of bed is elevated about 30 degrees, and their head is tilted to the side to drain secretions. After they're done, you obviously want to monitor their vital signs and airway. They did have a tube shoved down their throat. It's a pretty violent procedure. They might have cough or dry throat. You can give them candy or lozenges to aid in that once their gag reflex is returned. But before that, you want to withhold fluids to make sure their swallowing is adequate, not going to compromise their airway. It says you can discharge their IV, but if the patient is still sick and going to be in the hospital, you're not going to do that, obviously. Um, they probably will have lasting effects of this sedation that they're under, or they might have slight painkillers used or something like that. So you want to make sure they're not going to operate any heavy machinery for about 18 hours, anywhere between 12 and 18 hours after the procedure. So going in from the other end, we have a sigmoidoscopy or a colonoscopy. So that allows us to visualize the rectum, the colon, the transverse, ascending, descending colon, all the way. I think you not even get up to the appendix and view the appendix this way. So this one you do need bowel prep for. It's polyethylene glycol. I don't know how much they have to drink of it, but it's kind of a lot, and it cleans them out real quick. And you're going to be a busy nurse that night or day. You want to make sure this patient has a low residue diet before. Obviously, sometimes if it's an emergency situation, you can't have that, but if they're going in for a planned procedure, you can have them be low residue, low fiber. Uh, you can have liquid the day before, clear liquids, but then nothing by mouth before midnight. So you want like that 6 to 8 hour window of nothing in the GI system. Clear it out, make it as clean as possible, allow them to view it. And also, this can cause trauma, so you want to avoid anticoagulants, antiplatelets as directed by your practitioner before the procedure. So this allows us to identify early signs. So yeah, appendicitis, you can view the appendix, diverticulitis, polyps, colon cancer. You can, yeah. So I feel like after 45, you always hear men and women, mainly men, go and start getting them. Seems to be a painful kind of procedure. It's kind of what I knew about it before nursing school, but yeah, it's kind of how we're looking at it. So if you have it from 45 to 75, the identification is really effective. After 75, who knows? There's not like predisposing conditions that might allow you to know if you have it. So for this colonoscopy, they're going to be under moderate sedation, similar to the EGD. They're going to be left lateral recumbent, and think about, like, let's just think about this from a logical point of view, right? Procedure, vital signs, respirations might be decreased because of the sedation. Could be a traumatic experience. They could have bleeding, pain. You want to monitor their bowel function. Could have a perforated bowel or hemorrhage from the actual scope itself, or maybe just that's what they had and they need to go in for surgery to take care of that. So they can't, if nothing was like found during this procedure. I feel like that was a confusing thing. A lot of times these patients are kept in PO even after the procedure because they found something and they got to keep irritation out of the area. So you're going to want to resume the normal diet after their sedation wears off. Make sure their swallowing gag reflex is intact. They're going to be probably a little bit dehydrated, so we want to give them fluids. You want to monitor those bowel sounds because they're going in there and stirring up those juices and everything. They might have more gas. And then same thing about operating heavy machinery. Avoid this for about 12 to 18 hours after. So that kind of covers our GI diagnostic tests, right? So we did occult blood, we did our stool sample, regular one covered that. Also used to detect C. diff. We need that one. The EGD, that's the upper GI. The colonoscopy, that's lower GI. Kind of similar things. Just think about where you're going in. Urinary diagnostic tests. Okay, so urinalysis, this is a little more complex than the GI stuff. Urine tells us a lot about different things going on in our body. So we have different types of tests. We have our regular dipstick. You can get these at like your local pharmacy, and it can give you a lot of information about um, your blood composition because your urine is filtered blood. Excuse me, need some water. So there's also urinalysis that can be done in the lab. There's urine culture tests for UTIs and things like that. As far as like procedures go for the urinary system, there's the cystoscopy, there's an ultrasound, there's CT and MRI, there's a combination of using imaging and dyes to map the filtration of your blood. So let's start off with just good old urinalysis with the dipstick. This is a rapid test. You dip the urine in, and it gives you a variety of different meanings. It can be used to identify like specific gravity, the pH, like quantity of leukocytes, if there's blood in your urine, nitrates, ketones, urobilinogen, proteins, and glucose level of your urine. So that's just the basic dipstick. Rapid urinalysis test. The culture and sensitivity test is typically done for anytime we suspect a infection. This should be a clean catch procedure. You want to catch midstream, instruct the patient to clean their perineal area before catching this urine, or you're going to do this for the patient probably. This test is then sent to the lab where it undergoes testing to see which antibiotics it responds to. Careful with these containers, they're sharps, they have needles in them. They should be disposed of properly, but the little tubes can just go in the tubing system. Sometimes you might have a patient with an indwelling Foley catheter as well. This catheter can be used to harvest, clean, and catch urine. Not exactly sure what the procedure is for that or if we're going to go over that, but we'll find out down the road. That's culture and sensitivity, so it's used to diagnose UTIs, kidney infections, other issues with your urinary system. The 24-hour collection is used to measure kidney function, creatinine clearance, urea nitrogen, sodium content, calcium, catecholamine, and protein content in your urine. So the way you want to do the 24, wait, actually, do I have a slide about that? Yes, we'll talk about that in a bit. Okay, so next up is um, the KUB. This is a X-ray, as you can see, of the two kidneys with their blood flow, the ureters, all that good stuff. Shows the complete urinary system. It's also used to diagnose like a variety of other issues as well, feeding tube placement or stent placement, gastrointestinal conditions, foreign body obstructions. It's just an X-ray of your abdominal region to tell what's going on. The dark or the lighter areas here you can see are harder. It shows calcification or like more dense structures. So you'll see calcification like kidney stones a lot of times. You want to have the patient be have them remove any jewelry or metal. It's not actually super necessary, but if they're going into CT, definitely, or MRI, definitely. Next up, we have the intravenous pyelogram. This is the one that uses X-ray and CT and the dye to map out the filtration of blood. Because this is using contrast, we want to check for a iodine and yeah, so you want to be worried about the shellfish allergy to it can be related to iodine as well. We might give the patient an antihistamine to neutralize any adverse effects of this. We have to get consent because we're using the dye, the contrast. The patient should be NPO 8 to 12 hours before the procedure. I think because the dye makes you nauseous and it's an aspiration risk if you're in a procedure. What else about this IVP? There's something else I wanted to add. Oh, it's hard on the kidneys. The dye can be really difficult on the kidneys, so people with reduced kidney function may have some more severe effects. When you go in there with your patient, you want to make sure that they've filled out that consent. They know all the risks and benefits and all that good stuff. Ask them about allergies to shellfish or iodine in the past. Again, they might need a laxative or enema, NPO before 8 to 12 hours before the test. After, you want to monitor their vital signs. Any reaction to the contrast, redness around the injection site, um, monitor just their vital signs in general, and give them fluids because they've been NPO. Um, with education, the effects of the contrast last about half an hour. So you're going to feel flushed and warm. Um, notify your provider if you have any severe symptoms of allergies and like hives, rapid heart rate, rash, difficulty breathing. Um, you might feel flushing, burning, nausea, and metallic taste in your mouth while that dye is being injected, but it should disappear after about half an hour. With the cystoscopy, looks extremely painful and unpleasant. This is used for the visualization of lesions, tumors, other things in the bladder itself. Um, you can actually remove stuff out of the bladder, biopsy something, or get up into the kidneys via the ureters. So pyelogram, assess the kidney function. With this one, it's an invasive procedure, so we're going to get a consent. We want to educate the patient what's going to happen. It might be painful. You might have blood-tinged urine, but that's to be expected. If massive bleeding occurs, that's a problem. Bright red, problem. Pinkish, okay. 30 to 45 minutes for this procedure, and you want to obviously increase the fluids after so we can flush the urinary system out. So, what are they going to do with your urine? We can look at the kidney function. We can look at your creatinine level, which is going to give us an idea of how your kidneys are working. You can look at your blood urea nitrogen. That's going to tell us a little bit less accurately kidney function. Your creatinine clearance, that's going to be pretty important. That's like a more accurate version of creatinine level. And then your filtration rate, how well are your kidneys functioning? So serum creatinine, first of all, is going to be an indicator of kidney function, kidney disease, anything going wrong with your kidneys, dehydration, uh, volume problems. It indicates fluid, what is going on with the fluid level in your body. Going to be important when we talk about fluid and electrolytes in unit, what is that, 20, I think it is. So it's probably the more indicative test that we do to identify renal function over blood urea nitrogen, because we'll go over it in a second, but BUN is um, influenced by your diet. So this can be, but it's not quite as much. It's produced when muscle cells are broken down, so you can have it after like intense exercise or increased consumption of protein, but not quite as much as BUN. So the normal range for serum creatinine is 0.6 to 1.5 milligrams per deciliter. Yeah, so you can have high creatinine, lots of protein, catabolism. Yeah, catabolism by from kidney disease, kidney obstruction, dehydration, increased consumption of protein, intense exercise, and certain medications. Low creatinine, on the other hand, may be caused by pregnancy. You're giving away all that protein to that baby growing it. Um, low muscle mass and extreme weight loss because you're breaking fat down, right? And not, yeah. Blood urine nitrate. This one is a sensitive but less specific indicator than creatinine because the level is affected by dietary protein, other non-renal causes like liver dysfunction or blood pressure can raise that level of BUN. Uh, the level is elevated for end-stage renal failure, um, after 50% of its function is lost. So we rely on creatinine more. But it is an important quality because if those other measures are controlled, it can give us an idea of why we have so much protein in our urine. Um, so 46% of this is nitrogen, 50% is urea. So it's blood urea nitrate. Our normal range for this is 8 to 25 milligrams per deciliter. I remember this one. When you have a bun, when do you eat a bun? Like a morning bun, right? It's going to be 8:25 a.m. in the morning, so 8 to 25. You're going to have that bun in the morning, milligrams per deciliter. Next up, we have our creatinine clearance test. This is that 24-hour test that we're talking about. So when you do this, you're going to start the 24-hour urine collection at the time of the discard of first void. So when that person voids, you discard that urine. It does not go into the 24-hour collection, but you start that timer, and at 24 hours on the clock, the same exact time the next morning, next day, whenever it is, you're going to stop that test. The amount of urine collected all goes to the lab. Meanwhile, this whole time it's stored on ice or in the refrigerator in a large container. This urine goes to the lab at the end of 24 hours. It has to be complete. You cannot have a portion, you cannot discard it if someone's lost because the client urinated. We have catheters for this reason, specific I's and O's. So when you drain that urine, it has to go into that container. If any is lost, if the client gets up and goes to the toilet and they poop and lose some urine that way, you're going to have problems. So we measure this by the creatinine clearance level. So our glomerular filtration rate, that is what we're trying to achieve. We measure the amount of creatinine in the urine, total, the volume of urine, total, in that 24-hour period, and then the plasma creatinine level. We divide that by the plasma creatinine level, so how much is in the blood. The normal range for this is about 85 to 135 milliliters per minute, I believe. And then anything under 60 milliliters a minute can be used to detect kidney disease. So if you look at this chart right here, kidney failure is below 15. Kidney disease is between 15 and 60. Early stage renal failure or renal disease is between 60 and 90, and then that normal range is like 90 to 100, depending on what is going on with the patient. Other factors might play into it, so we give it a range of about 85 to 135, but above 60 is important. Okay, that is it for our urinary system. Let's talk about cholecystitis, cholelithiasis. So cholecystitis, cholelithiasis, it means bile. Chol means bile. Cyst is that sac, the gallbladder itself, and then itis would be inflammation. So the liver creates that bile. It's then stored in the gallbladder as a reservoir, and then it's secreted into the small intestine upon digestion of food. So it's going to go in there and help break down the fats, the proteins, and the carbohydrates in the small intestine. So the gallbladder itself contains like salt and water, a bunch of different salts, different enzymes and hormones to aid in the digestion of um, food. The sphincter of Oddi, which is at the end of the common bile duct, is released in the response to the ingestion of fats. So this is specifically going to release enzymes that are important to the digestion of fats, and that's why we see patients after eating a large quantity of fatty, greasy food coming into the hospital or presenting with the signs of this cholecystitis, this pain in their gallbladder region. So cholecystitis is the inflammation of that gallbladder itself, but cholelithiasis, the calcification, the gallstones in that bladder are what cause cholecystitis most of the time. Yeah, so causes of cholecystitis are those gallstones. You could also have an obstruction in cystic duct. Um, this causes the buildup of those contents, the bile, to build up in the gallbladder, may cause irritation, and it may eventually digest that tissue. So the six F's of risk factors: female, fatty diet, 40 years old, family history of it, fertile, pregnant, and fasting. Signs and symptoms of this are going to be that positive Murphy sign. We'll talk about that in a little more in a second, but that's a real important one. Obviously, nausea and vomiting, because um, those small intestine contents are not being digested because the bile is not being released to digest it. A lot of times you might see a patient have NG suction placed to remove the stomach contents and relieve the pressure of digestion and nausea and vomiting because of this cholecystitis. The patient might be dehydrated because they might need IV fluids. Uh, this is one of the indicating signs is pain that radiates to that right scapula and gets worse after a greasy or fatty meal. So right scapular pain, um, not left. Left is cardiac. Right would be cholecystitis. Uh, they might have an enlarged abdominal area, kind of distended abdomen. They might have a fever due to the infection or due to that inflammation of the gallbladder region. If that tissue becomes inflamed, you can have um, a whole host of issues. And then liver dysfunction might occur as well because those liver cells are being affected. If that bile leaks out, those liver cells are being affected, or if it backs up, doesn't have a place to drain out. You might see jaundice, dark urine, light colored stools, that tan color, right? Because the fats are being not digested, steatorrhea. That's fatty, greasy, tarry, tan stool. It's gross. Murphy sign is the indicator for this. When the patient lays flat, they take a deep breath and you palpate on that right upper quadrant, kind of under the diaphragm. And when you push on that area, it's going to put pressure on the lower side of the liver and the gallbladder. And man, they're going to experience some pain if their gallbladder is inflamed. Sometimes we use an ultrasound to diagnose this. We can see the gallstones within the bladder itself. This is non-invasive procedure. It doesn't require sedation. It doesn't require any of that good stuff or bad stuff. So we're good on that front. We also could use a CT or MRI with contrast to diagnose it. We have a HIDA, which is similar to the intravenous pyelogram, but it shows the liver, pancreas, and gallbladder instead. And then the IVP was the X-rays with the contrast. And then we also have lab monitoring lab function that can help. So if we have increased white blood cells, that could show inflammation. Liver function tests show us, is the liver being affected by those um, leaking bile enzymes and all that stuff, digesting and interacting with the liver cells, causing them to not produce what they need to produce. Amylase and lipase. We're going to go over this in a lot more detail in a minute, but um, those levels are going to be low because we do not have it being released properly into the body. So we have this ERCP, endoscopic retrograde cholangio, cholangiopancreatography. Oh my goodness. We can view the liver, gallbladder. The endoscope goes through the mouth and goes down Up through the common bile duct and then into the gallbladder that way. It's kind of travels a long way, but it can also be used to visualize the pancreas, liver itself. So liver, pancreas, and gallbladder all there along the common bile duct down the road at some point. Sometimes they can remove the gallstones directly from the common bile duct with this endoscopic retrograde cholangiopancreatography. Some other treatments for this are extracorporeal shockwave lithotripsy. This is like some weird like radiation therapy thing. I can't really describe it very well, but it's a non-surgical, non-invasive means to remove small cholesterol stones from the gallbladder or common bile duct. It takes a long time, a lot of times. So it uses this ultrasound probe, shoots it in there, and breaks up the stones into smaller stones. That way they can be passed more easily through the GI system. They might need pain medications during this, movement of those stones, or like trauma to that area, or anything going on with that area that's already inflamed is going to cause pain. Bile acids. Um, these bile acids are very uncommonly used, but they can be used to dissolve the cholesterol stones. You don't want to use them very long. I'm not even going to cover those really anymore. Yeah, just be careful with those. Don't give them. Surgical treatments for cholecystitis. They can just go in there and chop you open and pull that whole sucker out, that whole gallbladder out. I'm not really sure. I think it ends up being okay. There's not really any problems. You might have to take some digestive enzymes afterwards. Um, but they're just going to remove that gallbladder. But they can also do it laparoscopically, and it's a much less invasive procedure. You can go home within 24 hours most of the time. Versus the open surgery, you're going to be in the hospital probably 1 to 2 days. Might have a drain in place to like keep all the secretions out. Just a much harder process. So if you're going that harder process route, you might also encounter a T-tube placement, which is used to drain that bile out, and provide some like blow off area, so there's not a buildup of that fluid coming out, and getting stuck again. Um, it might also facilitate the removal of those gallstones from that T tube instead of draining it all the way through your GI system or having to continue down that common bile duct. So you want to make sure with these T tubes that you clamp it 1 hour before and after meals. So that's going to allow the bile to drain into your GI system and help with the digestion of that food. You want to have it elevated above the level of the abdomen because you're gonna, it's gonna drain that fluid out if you don't. It's not clamped normally. You want to monitor the stool. So is their stool being passed undigested? Are we going to see that steatorrhea? The amylase and lipase are not reaching the food, so those fats are not being digested. Um, you're going to assess the wound site, make sure there's no weird drainage. The wound should be clean, dry, and intact. Bile peritonitis. And peritonitis in general is one of the most painful things a patient can experience. So you're going to notice severe pain. Call the care provider and get them to come look at the patient. Have surgery, come look at the patient because something's inflamed and down there, and they just got cut open. So we want to prevent that infection. The T tube is typically removed within 3 days, and yeah, we don't we don't want to bathe until that's removed. Just take a shower, clamp it in the shower. Yeah, so you're going to resume your activity gradually about 4 to 6 weeks. Because they went in through abdominal, you want to prevent tearing of that. Avoid heavy lifting. Advance your diet as tolerated. Obviously, be cautious with those fatty foods. Be aware of the signs of infection, drainage, pain, odor, infection, all that stuff. And then the color of the stool should return to brown in about a week once your amylase, lipase, digestive enzymes from the gallbladder, the bile, once those are normalized again. Diarrhea is normal because you're obviously not digesting those foods. The laparoscopic treatment with this is a much less invasive procedure. There can be free air in the area. That pain can also radiate to the pain that make it feel like they had the gallstones again. You're gonna have that pain under the right clavicle, the right shoulder, scapula. So you're gonna want to move them, have them ambulate regularly to get that air out of there. You're gonna monitor for infection. They still cut them open, still went inside, but it's a lot less invasive. And then you're gonna start them on clear liquids once their gag reflex returns. And yeah, you're gonna keep them on a low-fat diet, light meal for a few days, and then advanced diet as tolerated, advanced activity as tolerated. Okay, so the pancreas, pancreatitis, inflammation of the pancreas. So um, digestive enzymes of the pancreas, as you can see here, or gallstones sometimes block the common bile duct, which is important for carrying not only that bile to the small intestine, but also important enzymes and hormones like insulin, glucagon, somatostatin, amylase, lipase, those things. So the pancreas um, is found in the upper abdomen next to the duodenum. It connects to the common bile duct, and it contains a variety of like gland cells, acinar, and there's the other ones that are the islets of Langerhans. These secrete specific digestive enzymes. Acinar cells specifically secrete amylase to break down glucose, protease to break down protein, and lipase to break down fat. These are released in the inactive form in the pancreas into the common bile duct, and then once they reach the small intestine, they're then activated. The islets of Langerhans is responsible for secreting glucagon, uh, insulin, somatostatin, those other um, hormones that are going to facilitate or relate to digestion. Yeah. Epithelial cells also produce bicarb in the area, but we'll talk about that at a different time. The signs and symptoms of pancreatitis, blood sugar issues. Why? Because you are having uh, probably some problem with insulin secretion. Insulin is not reaching your small intestine. It can't facilitate the absorption of glucose into the bloodstream, into the cell. So you're going to have high blood sugar. You might have acides, that's distension in the stomach. You're going to have malabsorption. You're not digesting the food and absorbing it, getting the nutrients you need. So weight loss is a common side effect. Um, with your GI issues, you're going to have extreme pain, diarrhea, and oily stool. Again, that oily is that fatty substance. You might have fibrosis with permanent damage, which the cells become hardened and cannot produce these enzymes and hormones again. That's a severe case only. And shock or respiratory distress. This can really cause a lot of issues. So you have acute versus chronic pancreatitis. Acute is going to be that sudden onset, quick inflammation, quick something triggered it. You maybe drank, you maybe ate a fatty meal, and man, something went wrong. Gallstones can cause this. A lot of times, that's the issue. Alcohol abuse can cause this. So this acute irritation is reversible for the most part, but if it's untreated, or you have chronic pancreatitis, or chronic acute pancreatitis, then it's going to lead to that chronic pancreatitis. Um, Man, these inflammation, The inflammation in the free enzymes and the things that are supposed to go to the small intestine leak into the GI system or into the abdominal cavity and cause crazy dysfunction. The lungs can be affected. How crazy is that? It's not even related to it, but the lungs can be affected. Respiratory distress. You can have bleeding. You can have digestion of tissue. It can get really bad. So this chronic is caused by repeated episodes. A lot of alcoholism, uh, alcoholics present with this. This is irreversible, and these cells become damaged to the point where they're fibrotic, they have cysts, they're calcified, they do not secrete these hormones and enzymes that we need from the acinar cells and the islets of Langerhans. Acute pancreatitis, again, we said it could be caused by gallstones, which are hardened deposits of undissolved cholesterol salts or bilirubins blocking that common bile duct. Buildup of the digestive enzymes in the bladder can cause activation in bladder, causing acute pancreatitis. So these problems are all related to each other. Alcoholism can cause damage to the acinar cells and the pancreatic duct cells. That epithelial tissue is responsible for bicarbonate excretion and managing the pH levels in our body. So chronic pancreatitis is associated with long-term alcohol abuse. Cystic fibrosis can occur, or it's common in cystic fibrosis as well. Thick mucus production. Yeah. So diagnosing pancreatitis, we're going to use that endoscopic retrograde, whatever, pancreatography to assess the pancreas, bile ducts, gallbladder, maybe remove gallstones. We're going to use a CT and ultrasound, and then we're going to look at the blood test. Amylase lipase. Is the glucose level elevated? So when they get there, we're going to look at their pancreatic enzymes, lipase, amylase, protease, tumor markers, risk factors, other things. We might send them to a CT, diagnose gallstones, maybe an MRI, and maybe an ultrasound. Then after that, they might go to a PET scan. They might have, if we really need to know what's going on, they might get in there with that endoscope and look at everything. Yeah, and then we will diagnose that we're not we, the physician will diagnose the patient. Some signs and symptoms of acute pancreatitis are sudden, very painful mid-epigastric pain, pain of the left upper quadrant radiating to the back, and then it gets worse when you're laying down. Pain coming on after drinking or eating a fatty meal, fever, increased heart rate, decreased blood pressure, nausea and vomiting, digestion issues, increased glucose levels, increased amylase and lipase. Okay, so then we have these two signs here. Colon sign is that belly button in the middle with the bluish discoloration around it. Colon sign is a circle around the belly. Turner sign is on the flanks, and this would be a bluish discoloration as well. These are, yeah, these are positive signs of pancreatitis. So, goals for our nursing interventions are going to be controlling the patient's pain, making sure that the work on the pancreas is reduced. We want to be aware of actual problems and then watch out for Jason or whatever that guy is and potential problems that may arise. Administer the medications as needed. So the patient should be NPO when they get diagnosed with pancreatitis originally so that the enzyme production is reduced. You can reintroduce liquids slowly, but no fats at first, no hard to digest things. You want to maintain their hydration and nutrition throughout this, so they might be on TPN. The nasogastric tube might be needed to remove the secretions out of the stomach, so it lowers the demand on that GI system even more. You want to monitor the stool and urine colors, greenish tan. Are they normal? Give them pain medications. The pain is pretty severe, so they're going to be getting some pain medications. Probably IV, right? Because we want um, parenteral stuff. Medications to stop acid secretions. So what are those? Protein pump inhibitors, H2 blockers, histamine blockers, and antacids. And then severe cases, you might give them actual creon or pancreatin, which will break down the fats, carbs, and proteins in the absence of the normal pancreatic enzymes. You want to mix these with acidic foods, not alkaline foods, applesauce, not milk. Um, and then as what else? Oh, patient positioning. You want to have them sitting up or leaning forward most of the time because laying flat makes it worse for them. So for the nutrition on this, you're obviously going to want them to reduce their alcohol intake. You want to reduce greasy and fatty food intake. Um, eat low fat, small, unseasoned meals. Eat foods high in protein. Protease is less affected, so you can digest protein still. Carbs are still amylase, and lipase is still for fat. So keep those down. Limit the sugars, refined carbs, and eat complex carbs that don't jack up your insulin, because with your pancreas you might have insulin blood sugar issues, and eating fruits with a low glycemic index, something that doesn't jack your blood sugar up, like a simple white bread or simple sugars, fruit juice, or yeah, fruit juice and things like that. Yeah, so this has been pancreatitis. It's been the GI system, the GU system. Again, I used the registered nursing RN um, to help with this. I've used our class slides to help with this, and then I've referenced the little graphs and stuff here. So this is number 2.